So really quickly, no financial relationships to disclose. I'm not smart enough to develop those. This is an overview of kind of the topics that I'm going to discuss. So as Dr. Park alluded to, a whole lot of topics that we'll run through. Some of them I'm going to go through exceptionally fast. I promise I didn't collude with Dr. Bell, so you'll see some same figures that we have both adopted, but I think that the lesson there is that these are very applicable both to the type of unit that I'm going to be presenting on, as well as to the broader hospital environmental infection control issues that we see plague every day. Aside from that, I really do want to acknowledge Dr. Park and her team. So as Emory, Nebraska, and Bellevue are doing this national training center, and we're charged with going to all 50 states over the next 2 years. The states that we've already visited, I can tell you there's this broad spectrum of interaction between hospitals and health department and kind of the relationship and collaborations that exist there. Some are extraordinary, and I think I would loop the Hawaii group into that based off of what we've seen. Others are tenuous or contentious, and I haven't seen that here. When we were planning our trips, we spent the last 2 days touching 5 hospitals here on this island. When we were planning this trip, Dr. Park was a strong advocate for the hospitals of Hawaii. We have a general idea of how we're going to conduct all of these visits, and she assured us that was not adequate for Hawaii, that we needed to go to more than just a handful of hospitals because you are on an island both geographically and logistically. So I think that hats off to her. Now that we are here, we have a renewed or a new appreciation for that aspect and how it impacts what you guys do. And I would also take that opportunity to validate all of you that are here for this preparedness conference, right? Because the role that you play is important in that role on the mainland, and I think out here it's even more important, right? Because you're the front line and in some cases the only line. So I just wanted to validate that, and what we've seen is a lot of people committed to protecting the health and well-being of everyone on these islands, even the transient populations that you deal with, which I think makes your job a little bit more complex. So really quickly, there's the list of everything we're going to go through. Thought I'd lead off with a picture of one of our patient transports. So we've discussed this with some of you that we've touched base with the last 2 days quite a bit. Just to highlight the need for strong protocols, but flexibility as well. This particular transport, it's probably poor form for me to point out that 2 of those people are in different PPE than the rest, right? Perfectly okay, perfectly appropriate. This ended up being probably the most patient transport, the most complex patient transport that we did, and interacting with some of our colleagues, one of the most that was seen. This was a patient that essentially arrived on our doorstep non-responsive and very wet and fluid as well. So it took, whereas most of our patients were able to either walk off of the plane or be assisted off by 2 individuals. As you can see, there are 4 individuals playing a pretty hefty role here. I'll also point out that they're doing that on a truck. We never had any plan that involved a truck until about an hour before that happened. So in terms of establishing relationships, we happened to have a relationship with our local airport that was more built around where can we do this. That quickly evolved one night to what do you have that we can use, which was a very difficult conversation for the airport to wrap their head around. You might potentially contaminate some of our equipment with what? Ebola. So having that relationship was an exercise in being flexible for everyone. So I wanted to lead off with that. To inform both the conversations that we already had in the breakouts and this morning and what I'm going to present, I just wanted to highlight this. This is the infectious dose figure for Ebola, to put it in context with influenza. The general infectious dose being 1,000 virions for influenza, 100 for HIV, and then 10 or less for Ebola. We've had one lab study where they showed it with 1 virion resulting in infection of a primate. On the flip side of that, the number of subsequent cases that come from an index case is, generally speaking, only 2 secondary cases, right? And this also follows with what we saw in Dallas, where we had some exposure and we had 2 follow-up cases. Not quite as highly transmissible as measles, mumps, SARS, or MERS, or even HIV. So these are all things that kind of informed our approach, and these are all aspects that we educated our clinical staff on that they don't normally get, but that helped them have a full, detailed understanding of what they were dealing with. Again, contact transmission. So as we get into kind of our rationale for how we develop protocols, this was central to how we did that. Our unit had always been faced toward an airborne isolation, and so we stepped down some of those things that I'll discuss for you today, and this is why. So a lot of what I'm sharing with you has been published, and I've just put these in here so that if you come and access the slides later, you'll know where to go and find more information as well. So again, what am I going to be talking about? The experience that we had from receiving 3 confirmed Ebola patients, fully acknowledging that we had 72 hours notice of we were receiving someone that definitely had Ebola. So other situations, you have a little bit more of a handicap than that, right? You're going to have someone come through your door who's screened and you're responding to that, or they come through the door and they've been screened and they're positive for something, but we don't know exactly what it is. So a lot of what you're doing with respect to Ebola will be adapted to those situations. And then again here, this is more standard how we isolated all of the patients that were medevaced back to the US, both at Emory and University of Nebraska, in a Tyvek suit and then some sort of face mask if they tolerated it. And all of the patients that were medevaced back were able to tolerate that with the exception of the first photo that I showed you. So here's the figure that I mentioned a little bit ago. I assure you, Dr. Bell and I did not collude. But this was really central to how we stood up our unit, and we didn't apply it in just a singular fashion in terms of Ebola patient in the unit. This actually became central to how we developed our protocols for sharps management, for waste management. We really wanted to apply this concept. So as was mentioned this morning, in terms of the hierarchy of controls that we can put in place, with the top being elimination, substitution, replacing that hazard, which again in this area it's really difficult to substitute the hazard, right? But when we start talking perhaps sharps or glass lab specimens, we can start to apply those types of hierarchy of controls, okay? So that's where that comes in. Engineering controls, this is a major one, whether it's a patient isolator with HEPA filtration, or it's a negative pressure room, or an autoclave if you go that route. So there's a number of different of those. And then administrative controls. This is one of the things that we talked about. I've talked about individually with a number of people when the concept of Dallas comes up and what happened in Dallas and the fear that might happen here. And really what I have relayed in most of those personal conversations this week is that you guys are already ahead of that because you have administrative controls that exist today that didn't exist then. Some of that is a staffing plan, right? So we know that you would have an altered staffing plan. You wouldn't have all of the staff on that unit going in and out of that room like they do with other patients, because you would hopefully screen and identify and then activate some sort of plan. So you have administrative controls that distinguish that from that. And then lastly, PPE, right? So in healthcare, we frequently tend to go to PPE as the first line of defense. And I apologize, the people that came to my breakout, we covered this ad nauseum, right? So I apologize. But for instance, PAPRs. Nationally, after Dallas, we had the mayor and the governor of New York go on to a press conference and hold up a PAPR, saying this is the best that's out there, this is what all of our people are going to have. We had some nursing unions that went on TV and did the same thing. And what is unique about that particular conversation is that a PAPR is not evaluated or validated whatsoever for contact precautions. Right? So we have PAPRs on the market that are not fluid impermeable. We have PAPRs on the market that have holes in the front. We have this whole spectrum of PAPRs, and they're all perfectly valid to be used as a PAPR, which is for air filtration, which is what NIOSH certifies and validates them for. All of these are acceptable to use. It's just knowing and understanding how they're validated, what they're validated for, and knowing that what that means for you is you have to figure out the weaknesses for how you're applying it, and how you can buy down those weaknesses either through administrative controls or other engineering controls, so on and so forth, okay? I promised everyone that we talked with the last few days that I'd give an overview of our unit and Emory's unit, because we talked a lot about distinguished procedures and protocols. So really quickly, this is our unit. Here is the external-most door, so that means a little bit more to the people that were in my breakout. We talked about a roof leak, right, that happened outside of our unit and where that leak came. So this is the external doors where our patient comes through. This is our staff entrance and our staff exit. They're separate. We have this long linear corridor, and we placed our patients in this room. And our ideal situation is to place patients in the furthest two patient rooms if need be. And really this is to use this long corridor to our advantage, right, to buy down risk of contamination being strewn throughout the facility. To do this, we use this entire corridor as a warm zone, and then point sources of the pathogen being our hot zones. We ended up, after patient 1, moving a lab into the unit, and this is really to buy down turnaround time and some other issues we'll get into in a little bit more. So this also opened up into our warm corridor. We had a waste holding area. We'll cover how much waste we generated per patient, which was off the charts compared to other patients that we deal with. And we've had a lot of conversations this week about that. So keep in mind that we've got successive hot zones that dump into a warm corridor, and then we've got a clean section of the unit, okay? So you get a sense of we've got hot, warm, cold, and that's going to drive protocols and procedures. Here's Emory's unit, which has a different footprint and different layout. They've got 2 patient rooms as well, and then this central corridor. And as you can see demarked, it might be a little bit difficult, is these red boxes that kind of overlap the inside and the outside of the door space, which is really their warm zone. So same principle that patient care room is hot zone, and then they have this demarked warm zone and then a cold zone, okay? So a little bit different concept. So our procedures that involve hot to warm, warm to cold, have to span over 30 feet, right? And theirs span over 40 feet. It's not that one is better than the other, but how you act in those crossovers and in those spaces is going to be different based off of that footprint, okay? So hopefully that adds some context to all the conversations we had with the 5 hospitals on this island this week, and perhaps more as we go. So our unit for 10 years, what did we do for 10 years before we saw our first patient? Well, we did a lot of research. We did a lot of research, and we did a lot of research. Here's just a general overview of some of those. So we did decon studies evaluating gaseous chlorine dioxide and vaporized hydrogen peroxide. This is about 3 years worth of work evaluating those pathogens both for room decon, complex equipment decon, ambulance decon. We get snow and cold weather, so we did studies in snow and cold weather to see how those agents would act there. We learned some hard lessons through that as well. Mathematical modeling of pathogen trajectory in our rooms. This helped inform our healthcare staff in terms of where to stand to minimize exposure. This was more relevant for an airborne illness, but we found out, I usually include the photo, and I didn't, so if we have a patient laying down and they cough, we get this nice plume and then it goes directly down. So in that event, where's the safest place in the room? Where's the most hazardous place in the room? Our personnel know that. Coincidentally for us, safest place is at the foot of the bed based off of the engineering controls of air handling and how that's set up. Different for each patient room depending on that. We also vaporized hydrogen peroxide, decontamination of medical equipment, autoclave evaluation. So an autoclave is an autoclave, right? Well, we typically use it for device sterilization, and how we were proposing to use it is for waste sterilization. So when you talk about putting a bag of waste in an autoclave, sterilizing all of that waste is a little bit different. So we did this whole validation study with biological contamination and then going in and culturing and validating our approach for different loads of waste. Evaluation of appropriate PPE use by employees. This really informed tweaking our PPE policies and procedures, and also informed outside of our unit kind of broader protocols. And then we also do some device research with manufacturers. One was the thermal detection systems that they use at airports, generally in Asia to screen travelers. So we implemented that in our ED during influenza season and validate it with thermometers. So in terms of infection control procedures, I'm just going to rattle off some so that you understand what that research was working towards informing. Donning and doffing of PPE, designating the zones for donning and doffing. So again, when you think back to the overviews of our 2 units, the zones are very different. So the location for where we did that was very different for our 2 facilities. Also designating those clean and dirty zones, zones for what task would be performed where. So we've seen a lot of reusable pappers on the island, right? And we've talked through, well, where do we use those pappers, where do we take them off, and where do we clean them for reprocessing? So these are all considerations for that. Complex equipment cleaning, daily cleaning checklists, designated pathways for removing waste. So you get the idea of the types of things that we were working on for the previous 10 years and honing through. Also, full disclosure, they changed when we took our first patient. So best laid plans, right? We still use those plans and they're effective, but we always feel as though we can do better. And I think that's the challenge as interest in Ebola or emerging pathogens wanes, is to keep that we can do better approach to keep things moving forward. So again, this is just a study where we evaluated personal protective equipment technique, or I should say technique failure. Everyone that we evaluated in that particular study had some sort of a breakdown in protocol on how they used. And that was more focused on putting on the equipment, not in our high-level isolation unit, but airborne precautions in the hospital, putting on the equipment, going into the room and doing multiple tasks, and then coming out. And for everyone, we saw some sort of failure. So coming back to honing in on training. As I said, all of our protocols adapt and expand over time. We use this unmcheroes.org to try to share a lot of that, whether it's human remains processing, using this patient isolator, or our PPE protocols. They do a great job at doing videos showing how we do it to relay to others. I don't put that up there because I think you should go look at it and do exactly what we do. That would be a bad idea because we have different equipment than you and we have a different space than you, right? But you can look at this and get a sense for the rationale that we used in the approach. So how we made decisions based off of that risk assessment that was discussed this morning. We're always evaluating risk in everything, whether it's overarching how we function our unit or minuscule what piece of equipment we take off in what order, right? So we're always looking at ways to buy down risk based off of that triangle that we showed you. So what's important about Ebola? Why was there so much fuss about waste with Ebola? So it's regulated different than regulated medical waste. It's category A infectious substance. So this is actually governed by United Nations regulations. And then the preeminent US regulation is Department of Transportation regulations, okay? Also noting that local rules and regs have to be followed first. I'm not aware of many local rules and regs that are more robust than the DOT or the United Nations. So those are generally kind of the default regulations in terms of packaging, what's required to move it on a road, and all of these things. So what constitutes Ebola waste? Anything that might be contaminated with Ebola, right? So if you are packaging, placing a whole bunch of equipment in a patient room and you treat a patient in there and the patient is under investigation, you don't know if they have Ebola yet or not, and you discard it, that's category A infectious substance because it might be contaminated with Ebola waste. If you hold that waste until it's ruled out, once it's ruled out, it's not Cat A infectious substance. So we took a lot of late night phone calls from folks that had what they deemed was a credible person under investigation for Ebola. And a lot of times we'd talk to them about batching and holding that waste because once you start the Cat A process, you can't unring that bell. Once the truck that is being GPS tracked and has a hazmat response team ready for it and all of these other things, it's not like you can just call them up and say, hey, never mind. We can stand down all that. Don't send us the $1 million bill when you're done, okay? So just things to keep in mind. The exemptions from that include human remains, anything going for interment or cremation or medical research, laundry or medical equipment complying with OSHA bloodborne standard pathogens, and then anything that's going to be refurbished, okay? So if I have a portable x-ray machine that was used for care for Ebola and we need to send it out to get fixed, that doesn't have to fall under Cat A rules. If I'm sending it out to dispose of it, it does, okay? So those are just some distinctions. And at the bottom here, we've got the US DOT reg reference if you need to go find that. Very early on in taking our first patient, we realized, oh my goodness, waste is a huge issue. And at that point in time, there was disparate guidance out there from different organizations, whether it was waste handlers organization, CDC, DOT, about what you needed to do here. The good news is over time that was aligned. although the category infectious substance with respect to clinical care is still an issue, and the federal partners have formed a work group to start working through that, although I am told that the work group has been put on pause because of the water contamination issues in Flint. All right, so in our patient care, what did we do with waste? Well, we had distinct waste streams. We had solid waste coming out of the patient care environment and solid waste being generated as we doffed our PPE out of that environment. Liquid waste, healthcare worker linens, and patient electronics. Yes, patient electronics. Every one of these patients came with not just one phone, but a phone, a laptop, photography equipment, you name it. And it was important enough not to leave it where it was. So these were all things that came with them, and we had to figure out what in the world do we do with this now. So those were all waste streams that we set up. So we talk about quantity of waste. Here are our raw numbers. So for the 3 patients that we saw, we generated anywhere from 100 containers of waste to 34. Event 3, that patient was with us for less than 2 days. Okay? But generally speaking, about 450 cubic feet to 150 cubic feet. Again, this is a little bit misleading because we had an autoclave. We had a vacuum autoclave. So what does that do? It shrinks it. And with our PPE doffs really big, and after it goes through a vacuum autoclave, it's pretty small. So you can probably quadruple those numbers, and that will be more reflective of what you see and what you can expect. Our colleagues at Emory have talked about a truck a day that was coming to pick up waste and haul it away. And then at weight and quantity, we hit anywhere from 1,000 to 2,000 pounds per patient. Okay? Side note, because I know that you don't have autoclaves to process waste, but for us to process all of this waste, about 4,000 or 5,000 pounds of waste from 3 Ebola patients, the final bill for that was $2,500. One of our counterparts that treated 1 patient and disposed of all of that waste as Cat A, $1 million. So there's a vast array, and I don't think those numbers would necessarily hold true for Hawaii. The complexity and what drove costs there was that on the continental US, there was only 1 location that would take it for incineration and 1 location that would take their ashes, and they were nowhere near each other. So the logistics in moving trucks from those sites to the point of origination was different, right? And we had state governments changing hazardous material regulations overnight to disallow that truck from passing through their state. So now you know why there's a work group working on this, right? Because it's a really complex but important issue. Liquid waste, we talked a lot about this in our visits this week. CDC guidance is that Ebola contaminated liquid waste can go down the sewer, and that any wastewater treatment center in the US can handle it. That is absolutely 100% correct. It can. We implemented some disinfection, and Emory did as well, of liquid waste before it went down the sewer system. This was born more out of worker protection. We talked about plumes that come from a toilet, so we were really working around that when we implemented it. The first 24 hours of our first patient, guess who was at our door? Public Works, plumbers unions, and our facilities group, saying, what are you putting down the toilet? Okay? So that was kind of a lesson learned for us. We had done a poor job of engaging those partners. That wasn't something that we had thought through. Did we have better things to do the first 24 hours of that first patient? Absolutely. But was there immense value in having those conversations with them at that point? Yes, they needed to happen, and they hadn't happened. As soon as we explained that we were pre-treating, that put them at ease. They went on their way. Is that scientifically valid? No. There's not a disinfectant on the market that's been evaluated or marketed for disinfecting pathogens in X volume of patient stool. So we were all kind of adapting with what knowledge we had for that. But again, it seemed to put our partners at ease. Let's keep moving here. So again, I showed you the differences between our 2 units and how does this really work. So this is a slide that we developed in partnership with the CDC and some talks that we give specifically just on waste. And really what this allows us to show is implementation of a hot zone, a warm zone, and a cold zone. And they've got a line here delineating hot and cold, and that's really the line delineating contamination from no contamination. But in terms of waste processing, the process that would be implemented here to reach that final disposition as Cat A packaged compliant is the final receptacle is put in this clean area, right? And then you have primary packaging of waste in the patient room, passed out into secondary packaging, and then it's moved into the final packaging over the clean line, okay? Is this the way it has to be done? No, there's different iterations. There's groups that feel like it's more important to put it in the full packaging in the patient room. What does that drive downstream of that decision? Well, you have to clean the outside of that packaging. So at one point, our waste vendor, we went away from hard-sided plastic barrels to cardboard. So had we been doing that, when we made that switch to cardboard, we would have had to change our protocol, right? Because we're not going to bleach wipe the outside of a cardboard box. But these are all options, and this is just kind of that strategy to thinking through, at least in this space, zones of contamination to buy down risk, and then implementing protocols across those zones to further buy down and limit risk, okay? This has not been presented as an issue here, but in terms of once it's autoclaved and that autoclave has been validated, it can then be moved as regulated medical waste much more readily. Environmental patient discharge and environmental decontamination, so we're talking terminal room cleaning is what we're getting at here. And we had a few questions about this leading up to this, and then also environmental infection control. So again, I'm just linking all these papers so you can go see them. This was one of the studies we did over those 3 years, looking at the gases, and this was looking at ductwork that spanned about 8 different floors of a university tower. We had a select agent rule-out lab, and its negative pressure air handling spanned 8 floors. Actually went through our medical library, that ductwork. And so we evaluated and validated how to decon with gas a span of contaminated ductwork. So just to put that in there, this is actually a picture from that. So you can see this nice creepy yellow haze behind us in the BSL-3 select agent rule-out lab. And this is what chlorine dioxide looks like. This is also one of the reasons we elected not to use it for terminal room cleaning for Ebola, was because there's an occupational exposure risk, right? And you can see that we're mitigating that with PPE here and some other things behind us. So we evaluated all of these as kind of a tertiary clean, and I'll get into that in a little bit more detail. In terms of environmental disinfection, we use bleach wipes in the patient room and in our unit. Our partners at Emory used a quat. Both are quite effective. Just pick what you're going to use with and stick with it, right? And we had a good laugh in our section about not using those together and chlorine clouds and things. So this occurred at all times. Any downtime that our staff in this unit had, they had a bleach wipe or a quat wipe in their hand and they were cleaning. So very vigilant. We also had key points throughout the shift. So usually for us it was shift change, where we had a checklist where everything on that list was clean. So we had assurance that every day this space was cleaned, right? So that was happening during patient care. For us, we had the ability to autoclave mop heads, but if we didn't have that, we would just dispose of them. We wouldn't worry about reusing them. Here's an example of that checklist. So I included this, so again, you guys can go grab it and see how it may or may not work for your facility as well. This was a study that we conducted over those 3 years. Interesting of note, we tried to publish it for like 4 years and nobody cared. Not super relevant that you can't kill pathogens in blood with these gaseous agents. Well, once we had Ebola, I think we got this published in like 6 days. They were really interested in it. And really, it's not a novel finding because with most disinfectants, if you have significant amount of organic contamination, so again, we're talking about pathogen contamination and then contamination of that pure pathogen, I suppose. If you have organic contamination, it's going to interfere with any disinfectant, right? So the strategy that was used at Nebraska and Emory was, again, manual disinfection. So blood got cleaned up immediately. We both have very detailed spill protocols, and in our hospitals at large, we have blood cleanup protocols. So this really becomes less of an issue when you realize that you're not going to deploy a push-button method, whether it's UVGI or vaporized hydrogen peroxide or chlorine dioxide, against pathogens in blood, right? The blood's going to get cleaned up first. So for terminal cleaning, as soon as we discharge the patient, and I'll go over the details of how we discharge the patient, even that was fairly detailed, we'd stand down that patient care room for 48 hours. Why? It was mentioned this morning this is an envelope virus. We knew we didn't have any blood reservoirs. That had all been cleaned up. This envelope virus, not super hardy in the environment. And in our particular unit, we get somewhere between 15 air exchanges an hour and 21, depending on what setting we have it on. If we don't flush our toilets every 5 days, they dry out. That's 1.8 gallons that sits there. Okay, so we know we're getting a lot of desiccation. So for us, that's an engineering control. We would use that to our advantage. So we stood it down for 48 hours. The other rationale here was our staff needed a break. Whether it was 2 days of intensive care trying to save a patient that came in non-responsive, or 21 days of care for an ill patient, they needed a break. So this gave them that break, and we knew that when they came back in, they'd be refreshed and ready to focus in on the task at hand, which was cleaning. We had a team of healthcare workers that came back in, not environmental services, and for us, this was born out of PPE competency. Our healthcare workers had 10 years of training with donning and doffing and knew how to function that equipment. We had not done that with our environmental services, so for us, the best decision was to use the people with that competency. So we came in with a team of 5 healthcare workers, and we also brought in infection prevention, 2 infection prevention providers, and their role was not to clean. Their role was to make sure everything got clean, to validate the methods that were used to clean. It was not uncommon for them to say, stop, go back to what you just cleaned, do it again. You missed the corner, or whatever. That's why they're there. Huge asset in this. For us, after that, we took in UVGI. Why did we do UVGI? We know it has limitations. Wherever there's a shadow from a UVGI generator, you're not getting any kill, right? Coincidentally, we were getting ready to do another study evaluating UVGI because we really wanted to clearly state in a clinical space what are the areas that don't get cleaned by UVGI. That's why we did. That's what we were getting ready to do that study. So we had 4 UVGI generators that had been donated to us by a manufacturer. And in lieu of the occupational exposure hazards and the limited efficacy against pathogens in blood, we thought, hey, we've got 4 of these units. If we put them all in the same space, probably not going to have a lot of shadows. So we went ahead and did that. We later went back and did a mapping, so an exposure mapping of the entire room. We get great exposure. About the only place we wouldn't get exposure is if you had a chair up against the wall. Directly behind there is pretty much where we weren't getting it. We're right now, I've got a grad student who's been emailing me all week. She's doing a study. There's a company that just developed a UVGI reflective paint, which is fairly novel. UV, why it's a good disinfectant is it doesn't reflect, it penetrates. So someone's come up with a paint that reflects it, and we're evaluating that now. We'll see how that goes. And then after that, others at that point, Emory, for example, used VHP as that tertiary clean, and then we would come in and do another 48-hour stand down. So why? In case there was any error in these first 3 steps and there was still that one infectious dose, we wanted to let our environmental engineering controls help us out a little bit more, right? And let that further desiccate the environment. So is this overkill? Absolutely. But we really feel like that's why we built our unit, is so that we could honestly turn around and tell our community that there's no risk coming out of this unit for you. So other considerations for you, personnel. Who's going to do the terminal room clean for you? So in New York, for instance, they have a contractor. They have unions to navigate. Their environmental services were not at a level that they could go in and do this, but there was a contractor available in New York that could do this. So they hired a contractor. There's a number of facilities in New York that I toured where that's the route that they're going, and that really is to navigate their employee situation and who's available that can do it. Location, medical devices. So how are you going to address medical devices? We talked about this in the breakout a little bit. You have ventilators, dialysis, portable x-ray machines, a whole host of things. We found early on that most medical device manufacturers also make a sleeve to buy down the risk of contamination. So this helped us, especially for our portable x-ray, which we take into the room. It was getting cleaned 3 times by bleach every time we pulled it out of the room. So before long, it was going to quit working on us. We found out that there was a sleeve system that manufacturer made for that particular device. and we used that, and that helped us reduce, one, the potential for any contamination on the device. Once we took off those sleeves, we had pretty solid assurance that any contamination went with the sleeve. This was also something that wasn't coming into contact with the patient. And then that helped us reduce our burden of cleaning from 3 cleans down to 1, okay? So again, it's looking at that triangle and implementing different levels of controls. And then also consider time out of service. We had the ability to take this unit down for a week. That's how long that protocol took to turn over. Not everybody has that ability. So condensing it, implementing a different protocol is adequate and appropriate in other situations. For decontamination, this is ambulance decontamination. We had a team of 2. We got a lot of questions about why drape an ambulance, right? Well, that was really born out of more the cleaning than risk to anyone, because there's all of those compartments in an ambulance, right? How are you going to get them all clean? It's going to take forever. I see the ambulance guys are like, yep. So both Emory and us adopted this draping system. We essentially do the same thing. We use different materials. They have a construction material that they've worked through. Emory has a much more highly trained EMS staff than we do. They have a dedicated staff that supports their CDC counterparts that might need to use their unit. They also support the international airport there. So they have this core group of guys that do a lot of training that's really focused on that. We don't have that ability, so we went with this 6 mil plastic. We go to any hardware store and buy a 50 by 100 foot sheet of this stuff and fit it to our unit. And now we have it to where we can drape it in about an hour. The other material that Emory uses is probably a little bit better, has a lower slip coefficient, but it has to be put in more pieces, which is why it's helpful to have a group that's highly trained to do that. They can do that quickly. If we tried to use that, it would take us a while because we don't have the ability to train quite as much. Same deal, we used UV. This was a consideration born out of our research. We tried to do the gaseous agents on the EMS services in winter, which was when we received all of our patients. Quick note, not an issue on the island. In really cold temperatures, the gaskets on the doors of cars shrink. So if you fill that car with a gas, the gas is coming right out. So we had to do a lot of taping to be able to do that and do it adequately. And so UV became the option there. And again, once we removed that barrier, what was the likelihood of residual contamination in the ambulance? It was really minimal, but we still went through and cleaned everything, both manually and with that tertiary clean, whether it was VHP at Emory or UV at Nebraska, just as another step of assurance, okay? For PPE, I'm going to go through this really quickly. I think it was said really well by Shelley, and Dr. Bell alluded to this as well. There's not a one-size-fits-all for PPE, okay? There's a whole host of options. I talked about PAPRs and the deficiency, at least for application against Ebola and how it's transmitted and how they're validated. There's TIChem, there's Tyvek, there's all of these different things, right? But generally speaking, what we're getting at is head-to-toe coverage with nothing exposed, okay? So that's the principle we're all working towards based on what we have supply chain and what we have cash for, all right? This is the CDC suggested PPE ensemble for a dry patient. Go through this. This is the recommendation for a wet patient. Note the difference, head to toe, nothing exposed, a lot of gear. What's happening here? Doffing is now a little bit more complex, right? We went from having about 3 items to doff to, gosh, we're probably pushing 12 or 15. So competency becomes very important in taking that off. Sorry, I skipped through that. So here's the PPE at Nebraska and Emory, just so that you get an idea of what's worked, okay? We had always been an airborne-focused, PAPR-only unit. 30 days before we took our first patient, we introduced an alternate level of PPE. It was developed by infection control, emergency management, myself, our leadership team. After we developed it, and we felt like we had a really solid protocol and rationale, we handed it over to the nurses that were going to be responsible to do this. And they looked at it and told us what was horrible and what wasn't going to work and what we were going to fix, okay? So we've been to a lot of your facilities. Some of you are at different stages of planning where you have a core group developing things, and others have already been through 4 or 5 full-scale exercises, okay? That's a key step to making sure you've got good protocols, is putting it in the hands of the people that are going to do it and having them tell you how they're broke, but how you can fix it. We do that with everything. Shelly's smiling over there because just last week we had our PAPRs out and our nurses were going through things that we feel like we can still do better, okay? But again, these are two PAPR models, different PAPR models, so they drive different ensembles with other things. This is a non-PAPR model, so what does it require? Fit test, right? We also have to have records that everyone has been fit tested, and people have to know what size they're fit tested to so they use the right one. So different considerations for different things. Discharge process, I told you that I was going to include this for you. This has been published. It might be easier to go look at that. It was a very in-depth, how did we let these patients leave the room process. At this point, were we still concerned about the patient? Absolutely not. Were we a little bit concerned about the environment? Yes. Even though it had already been taken through these daily cleans and we'd hit the checklist, at this point we were more worried about them walking through this potentially Ebola contaminated environment right before they go out to this huge group that awaited them for hugs and high fives and other things. So we implemented both a cleaning protocol. So I told you we had this long linear corridor. We cleaned that before they came out. They came out, they showered, they put on fresh clothing. Then we cleaned the corridor again. They went down that corridor the second time to the second shower, where both showers were CHG showers. And then once they took that last shower in the clean zone, they had clothes waiting for them. And maybe a barber and maybe some other things. They needed a lot at that point. They'd been so isolated. So there's a lot of information here. CHG generally is not considered to be virucidal. There is one study out there about if you prolong the exposure time or contact time of CHG, it does have virucidal properties, but we're not talking 100%. So again, is this completely science-based? No. Did we know that we were buying down some risk with it? Yes. So we made the decision based off of that, okay? Might be different at your facility. Management of the deceased patient. Know your state and local regulations. We've had a lot of talk about that. It sounds like it's been developed, but maybe still in development in terms of identifying who the specific partners are for the state of Hawaii and the various islands. Can Ebola be transmitted post-mortem? Absolutely. This is considered one of the highest risks, right? So the patients that have succumbed to the virus are generally very fluid, and their viral titers are usually off the charts at this point. So that, again, that fluid contact has a significant amount of risk associated with it. And a lot of the micro outbreaks that we saw in West Africa were actually traced back to handling of deceased loved ones based off of local customs and rituals. So this is important. CDC guidance: do not wash or clean the body, embalm the body, perform autopsy, or remove inserted medical equipment, okay? This is different from how we do it for other things. So just keep that in mind. Cremate when possible. I'll just say pretty much what we've said all week, that unfortunately this was one of the first protocols we wrote for our unit. The intent of our unit was that we're going to put people here that it's high likelihood they're going to succumb to their disease, but it's also a very communicable disease, okay? So unfortunately, this was one of the first protocols we developed. We were very glad that we had that protocol and that we had exercised it as much as we had over the 10 years. All of our staff knew exactly what the protocol was. And our MOU with our crematory, had we not had that, I'm not sure we would have been able to find a crematory the week of when we needed it. On the flip side, when we called them, they knew exactly what we were proposing to do. They had been preparing for it for 10 years. They didn't hesitate. What did they ask for in terms of assurance? One of our staff members accompanied the patient all the way to final cremation. And that was more from an infection control standpoint, assurance for that mortuary. They had a lot of insurance in our capability to provide that because we'd been telling them that we would do it and that we could do it for 10 years. If we'd have been telling them that for 48 hours, what's that worth, right? So just thinking through that as those people get identified and you start to have those conversations. They also knew when we called and made that ask that what they would be dealing with was a completely contained and packaged human remains. For us, they were not going to have a role in packaging those remains. So by the time they got to them, it could be handled with no PPE, okay? Very different based on your jurisdiction. There are jurisdictions out there with medical examiners, offices that have such a robust capability that they have their own PPE that they show up with and their own protocols, and they come all the way into the patient room and take care of everything. Okay, so just working through how that works in your jurisdiction, incredibly important. As Shelley said, we handled visitation of the patient through a video link for obvious reasons. This also was used for last rites. We made counseling services available to the family and also to staff. And we actually went so far as to have a service just for the staff. Although this was less than 48 hours, it had a major impact on our staff. This is very heightened. They put a lot into this situation. So our big recommendation there is a pre-existing MOU with a facility. We also had cremation orders pre-drafted by public health. So depending on your jurisdiction, who has the public health powers to do that, it's good to know who they are and to have those conversations with them beforehand in case they're needed. So this is just getting back to the viral loads at different days from symptom onsets. You can see if a patient were to expire on day 5 through day 10, what type of viral loads we're looking at having. They're pretty off the charts. Transport, I'm going to go through this really quickly because it sounds as though there's been a lot of planning on this here, and so my main recommendation for you all in the state of Hawaii is to close the loop on that. It's important to know exactly what the EMS provider is expecting of you and what you can expect of them, and then there's going to be some overlay that you've got to work out. Like, where's an ambulance going to be deconned? Is it in your ambulance bay? What type of impact is that going to have on the other ambulances that come in after that, and some things on that, and we'll get into that. So this is actually transport of remains. That was coordinated with the family, the funeral home, the state police, the city police, state public health, local public health, emergency management, our hospital, and the ME's office. Why law enforcement? Why emergency management? Well, let me see. We'll come back to this. Essentially because this is a vehicle transport. So if we were to have an auto accident, we wanted law enforcement right there and for them to know what was going on and for them to know what to do. That poor police officer got that call this morning saying, hey, guess what? You get to go accompany this transport. But it was helpful for everyone. So I've heard that you guys, the state of Hawaii has already published BioSeal, or at least a coalition. So that's definitely a high-level containment human remains packaging system. That's essentially what we used, and we did publish a paper on this that ad nauseum talks about how we moved remains from hot zone to warm zone to cold zone. Shelley had a nice picture of it where we used a slider board. So remains were packaged in BioSeal in the patient room. The outside of that was cleaned. Then it was passed using a slide board out of the patient room hot zone into the corridor warm zone. And as it was passed, they were passed into a secondary bag. Okay? And that was moved to the warm zone, cold zone line, and the same thing happened again. So we had first layer was BioSeal, and then the subsequent layers were like an 18 mil human remains bag. Okay? So again, we had practiced that a lot, and so our staff were pretty confident. Probably a lesson learned there is we pulled our staff from a diverse units, right? As a result of what units they came from, some staff were more used to being in that type of setting with a deceased patient than others, okay? So thinking through who it is that you're selecting and what their level of comfort or experience might be with that is also something to think about. This is back to that UNMC Heroes where Beth Beam, who is an RN PhD with our group, has put together a video of how that functions. So I already went over this. So again, this is just so that you can kind of see it. Patient room, primary packaging into a second package. We had to move down the corridor to go into a third. And actually when we came out of the external door, at our facility there's like a canvas shroud that's used just more for privacy. That's what we went into when we came out of the unit as well. So things to think about in terms of modesty cover, who that team is going to be that both packages or transports. Who is that? It's different for each jurisdiction, right? What is it for yours? How much are the hospital staff going to be involved, ME, mortuary, so these are things to just work through. Site and route of entry, security, chain of custody, and then emergency kits. So we had a spill kit that accompanied the patient remains, and we also had that staff member. That staff member had this huge go bag that basically had a few sets of PPE. So again, we're thinking through the worst case scenarios there. This is what the transport actually looked like. It was a fairly nondescript van that this is what they normally came to retrieve patient remains to take them, that group. So we went into there, and then our police escort. So again, there's the references for you. In terms of patient transport, so patient receiving, again, really high level coordination, EMS, US State Department, State Patrol, Omaha Police, this is our local police, FBI, State Public Health, Local Public Health, County Emergency Management, and Airport Authority or military base, okay? Sounds like you guys have already done some of this here, so that's amazing. Why FBI? Risk assessment. So we've talked a lot about risk assessment. This was a much higher level risk assessment. There was one transport on continental US of a confirmed Ebola patient where they actually asked the EMS providers to use body armor underneath their infectious disease PPE because there was deemed a credible threat on that transport, okay? So there's all these crazy actors out there, right? And these are the people that know about that. All of the subsequent transports after that, FBI was at the table, did their risk evaluation, and that was not a consideration. But it was really nice to have them sit there and tell us if there needed to be a consideration or not. Why state police? Well, we moved across jurisdictions. And so in our jurisdiction, public health powers reside at the most local entity. And so state police gave us some sort of attachment with a state authority so that they could coordinate with both state public health and the governor's office in case we needed it. Why county emergency management? Same consideration. Anything can happen in a car, right? So anecdote from one of the transports that happened in the continental US, there was a press vehicle that tried to break into the convoy. So we're talking ambulance, follow vehicle, law enforcement. Press wanted a picture of that patient in the ambulance so bad they tried to cut in front of the law enforcement, right? So were we glad that we had law enforcement escort? Absolutely. Was there a potential for an automobile accident? Absolutely. Is it best if emergency management knows what's going on? Absolutely. The other thing for us, this was Nebraska, and again, thank you, Dr. Park, for bringing me here. I left 12 inches of snow to come here, which is really hard, let me tell you. But cleanest roads I've ever been on. We had, first transport was done in the rain at night, second was done during an ice storm, and third was in a snowstorm, okay? Cleanest roads ever, because we gave them our transport route, and they'd been working on it for 10 hours before we got on it, okay? Very important consideration for us. And then, as I alluded to at the opening, that airport authority, and the guidance just came out from CDC on patient transfer, ambulance decon, air-to-ground handoff. All of this just came out, so there's new guidance. It's very SOP focused. But I cannot say enough about the importance of the airport relationships that we had established. That's not to say when we called them to let them know what we wanted to do on their property, they didn't pause for a minute to say, wait, you really want to do this? But we had a plan that had already been written, and at least tabletop, if not full-scaled, that we could go to, and everybody knew exactly where and what we were proposing to do. The only things that we really probably worked out last minute were chain of command for law enforcement, because we had multiple law enforcement agencies on base or on airport and so on and so forth. Here's the Phoenix Air airplane. Somebody called this the magic gray plane this week that will come and pick up your patients if you need it. We've talked about how isolated you are and the potential that weather could impede that or other factors. But this is the Phoenix aircraft, and this is the isolation unit that they deploy inside of it. This is really why they were the only group in the world that could do this. They were the only group that had designed and developed an isolation system that had been validated that could work in an aircraft, okay? So that's what we were going into or placing patients in. A little bit different PPE rationale pre-hospital than in-hospital. This was born out of lessons learned. Our first patient transport, we went with what we thought was scientifically called for, which was N95 and head-to-toe covering. What happened in that scenario? They got really hot, they started sweating like crazy, and what happened as soon as they did that? Before we even had the patient, I saw them adjusting their mask and their goggles, wiping their sweat. So clearly for us, going to a more comfortable PPE ensemble was incredibly important in that. Once we went to this, it was like having personal air conditioning, which wasn't the greatest when you stepped out of the ambulance into 5-degree weather. It was kind of like you woke up really quickly. But they felt very safe and secure, and we got rid of that discomfort issue and the potential failures in PPE from our use and discomfort in it. So I already showed you this patient handoff, and here it is again at the hospital, how patients were packaged. Our other option for patient isolation, I've seen this here on the island, pictures of it that you guys have this as well. We had always planned to use this. When it came down to it, we decided to go this route if we could. Again, it's less complex. Patients had to be able to tolerate it, but we still had great access to the patient if we needed it. Once they're in here, whatever happens kind of happens, unless we knew it might happen. So you have to put any medical equipment in there or have a really good idea of how you're going to get it in without breaking your field of isolation. So these are just considerations that we learned. This was always our go-to. When it came down to it, we ended up doing something that was more simple. Okay. Follow vehicle, I alluded to that. We actually had the medical director for the EMS service follow this ambulance everywhere. That was so that the medic in the back of that ambulance didn't have to make any decisions on their own. We had them in radio contact. If anything happened, they could call their medical director and get the decision made by them. So that was important for us. We also had a massive response kit in there, spill kit, more PPE, more staff that we could put in there if we needed to. Basically, this was our contingency. The other thing that's not widely disseminated, we had a second ambulance prepped and positioned in case this thing broke down. Funny note, our EMS service gave us the nicest squad they had for our first transport. We returned it so clean, they started bringing us their oldest, nastiest squad that you've ever seen. So that was their lesson learned, so you can think through that. I'm going to go through this real quick because we're low on time. In terms of laboratory, this was a major area of lesson learned for us. We always thought we'd need limited labs. What we learned through what our colleagues at Emory did was that the higher level of care required a higher level of lab capability, but that could be the difference between successful patient care and unsuccessful. So we wanted to accommodate that. Did we have some really difficult conversations with lab leading up to that? Absolutely. Because they basically said, you're not bringing Ebola virus into our core lab. We process tens of thousands of specimens a day, and you're not bringing that one bad one in. So we had to work through that. We had to be flexible. We had the advantage of having a public health BSL-3 lab on our campus, and so they stepped up and helped us with a lot of that. Initially, tests were ISTAT, electrolytes, malaria smears, and then the rest of the strategy was to transport specimens to CDC for confirmation testing. Prior to the first patient, we tried to expand, and we did expand to additional point-of-care testing for liver function, coag, and try to define where those could be safely performed. We're going to go quick here so that we can keep on agenda. So we defined this essential test list, and we started to develop this on-site laboratory concept while we had the first patient in the unit, because we realized our turnaround time to adequately package specimens, get them to that lab, and then get the results back was long. And this was kind of a stat lab type of situation. So we, between first patient and second patient, moved a lab into a patient care room next to it. That allowed us to cut some lab turnarounds from like 3 hours to an hour or less because of how much time it took to package and process out, so we weren't risking exposure to the rest of our facility. So that was operational by the second. Our lab, point of care lab, was right here, dumped into that warm corridor. So again, we were lucky enough, we have this massive research center. We found a biosafety cabinet with wheels and hydraulic lift. So I was really happy when we saw that. It made it much easier. Point of care testing, Piccolo, iStat, sealed rotor biosafety centrifuge. So as we get to, and I have some things that we were considerations for you to think about. We're going to skip ahead here to probably what's of greatest interest to you. So 2 papers have been published on what labs we performed and where we performed them. This was the one, we did a risk assessment of every piece of equipment in the clinical core lab, and basically came down to there was one piece of equipment that we could use. It was a closed system. It used closed specimen tubes that it processed. And so at the end of the day, that was the only piece of equipment in this massive core lab that we decided could be used. We still had to implement other protocols. So this dumped its waste directly into the sewer system, and we had already guaranteed our public works counterparts we wouldn't do that without pre-treating. So we had to time these labs and put bleach in the pipe that it put into. Again, was that needed? Not necessarily. A few months after we had a patient in here, that pipe backed up and water came flowing back up through it. I got a call. Everybody was really glad that we had been treating. Were we worried that Ebola might still be in there a few months later? Absolutely not. But that put everyone at ease. So there's a lot of this, fears and anxiety are high, and if you could do things to buy that down. Here's an overview of essential and supplemental tests used to support patient care. Also indicate the location of the laboratory that we did it, in the unit, in the core lab. So having that one large closed system analyzer opened up the types of labs that we were able to perform, which was great. This is a moving target. I'm skipping to the last slide. So here's where it is today. This is our lab menu that's posted in our unit. This tells our nurses that are operating in our unit what labs we might pull, what type of container that's color-coded for what type of container those labs need to be drawn into, so that it gets sent to the right place and gets put on the right piece of equipment. And whether or not it requires centrifugation, because again, we put a closed sealed rotor centrifuge in our unit so that would expand our lab test capability because we could do that safely in this isolation area before it went out, okay? So I wanted to put that up there so that you could go grab this later. I'm done.